that we are in a big stuck as far as health policy is concerned is, I think, a well-established fact. I think we are finally moving in the direction of beginning to acknowledge some of the hard problems that we face, particularly in terms of how to incentivize and make our health system more accountable for quality care. But how do we get there remains a big gaping hole. And I think for years we've spent grappling with the extent of the problem and bringing the sort of community of practitioners and researchers on board to acknowledge the extent of the gaps. And now really the challenge before us is how do we move from here? So we hope that this is the start of what would ideally be an ongoing conversation to think through some of the nuts and bolts of how do we move forward, and also think about what would be the most appropriate way of keeping a conversation like this alive. Jishnu visits India at minimum once a year, but if we can incentivize him to come more often, perhaps we can have a more robust conversation. But we do feel that a conversation is necessary, and today we hope is a starting point of that. So over to Jishnu. You have about 45 minutes to present, and then we can have a open discussion.
Thanks, Yamini. And just one small correction: I'm in Bombay and Patna a lot these days. Delhi mein kam aata hu.
Fair enough. It's difficult to get people to join.
Yeah, no, exactly. So just to, instead of saying, what have we done and things which I'll take you through, what Yamini had suggested and what I completely agree with is it might be more useful to think about how to move forward. And I think just trying to think pretty hard about what have we learned so far. And if we want to move forward, what are the kind of issues that we need to put on the table, and what do we need to start acknowledging on the policy front, and what do we need to start getting there, right? So I think part of the conversation is also about, are there pieces that are fundamentally missing from what we know so far? And if so, how do we fill them in, right? So I want to progress in the following way. I want to set up what I call a problematic, which is what is the deeper problem that we face in a particular way. I want to describe a set of results that I've been reluctant to talk about in general, but I think these are now close to what we call stylized facts, which is we find them in every environment we work in, right? I mean, so it's not key, this is only from Delhi or this is only from somewhere. This is broadly true of, I'll show you some all India results, and I'll show you lots of results from fieldwork in North India. So one gap is, we haven't done fieldwork yet in South India, so Kerala, Tamil Nadu might be different in some ways, right? I then want to discuss some key questions for policy, and just in terms of, where is this work coming from? It's fieldwork in Delhi, which started in 1999, then rural Madhya Pradesh, rural West Bengal, urban Mumbai and Patna, and then some all India work and experience with the RSPY program, right? So, the way I want to think about and this is one thing I should clarify is, as I've, spent most of my time in Washington and other places, the particular problem I'm going to describe is not an Indian problem. It's actually a global health issue, which is the way I want to frame it out is, the issues that India is going through is very much driven by the way global health has been constructed. It's not an India-specific issue, right? And that's worth thinking about, right? So if you think about most global health policies, including India, right? I mean, if you think about the JP Bhore Commission report and all the reports that have come out of that, the basic idea is rural India or even urban India is a neighborhood or a village, and it has a health post in it, right? And then the entire question becomes, how do we improve this health post, and what do we do about it, right? I mean, that's the framing of the problem. But that's not the reality, right? I mean, so this is Yamini, if you do the slides, I'll just talk up there. I mean, this is a village in Madhya Pradesh, which has, the village is here. It has two public sub-centers, only one PHC and one private provider. Next to that village is a large, is a very large village, which has close to 60 providers, right? And it has all kinds of providers in it. It has electro-homeopaths, homeopaths, MBBS, people without any training, integrated medical sciences, all kinds of Ayush providers. It's a very, very dense environment, right? So if you look at the kind of overall Indian environment, it turns out that if you do these right counts, just keep going, availability in rural India is very high, right? So if these are, per 10,000 people, doctor or provider counts in other countries, and this is all the states in India. So the way we collected this data is we went to a random sample of about 1,600 villages, and we actually counted everybody in them, right? So the global average is, just keep going, and the global average is this green line. India is just below it, right? So in every Indian village, the average rural Indian village, there are about 3.4 providers. Now, it's important to realize that these are massive undercounts, because it's saying, mere gaon ke andar, inside my village, how many providers there are? There are 3.4, but the picture I just drew for you is most people will go to the highway, or a lot of people will go to the highway close to the village. If you start counting those, in Madhya Pradesh, we counted that very, very carefully. It's a ratio of almost 4:1. So you can broadly assume that every village in India has access to about 10 healthcare providers within a 5-kilometer radius, within a 3-kilometer radius, right? What do these things actually, so how do these things actually look? Yami, next slide, please. So how do these things actually look? Even in urban areas, we have very, very large number of providers, right? So we've done these counts now. Our partners have done these counts in Patna and Mumbai, and you get a phenomenally large number of providers spread throughout these cities, right? So next slide. So just in terms of numbers, Patna by our measurement and our partners' measurements have about 1 provider per 750 residents. Mumbai is running at about 1 per 1,000. And these are, again, overall counts. If you look within neighborhood, a place like Delhi has about 70 healthcare providers accessible to each neighborhood, right? So the problematic, the way I want to think about it is there is... Sure, that might be better. Is that there's enormous choice in rural and urban India, right? Where does this choice actually come from? So the problematic I want to think about is, if you want to move from that model of there's a single health post in the village to an environment where there's enormous choice, we have to start thinking about what are the sources of variation in these data, right? So just to give you an example, when we started working on Madhya Pradesh, one of the people we met was somebody very high up who was a key designer of the NRHM, and he said, to understand the Indian health environment, all you have to do is understand that there are 3 tiers which start at the PHC and then go to the district hospital and then go to the top hospital, right? And that's just, it's a tiny sliver of the Indian health system. So what I mean by shifting our focus from saying there's a single health post in the village to saying that, look, there are 10 providers, they're doing all kinds of different things, there's all kinds of variation in these data. We need to start looking a little carefully at what does this variation look like, right? And how policies address this choice and variation, right? So the first, I'm going to give you 7 stylized facts. The first one I want to give you is that our health system is dominated by informal private sector, right? That's our biggest health system by far. So 80% of first contacts in primary care in India are with the fee-charging private sector. What people don't know generally is that 77% of private providers in rural areas do not have a formal medical degree, right? So public providers are more qualified, but they have a 20% market share, right? So really the biggest market share and the biggest sector in India is the informal private sector, right? Now, here's something which is very interesting, which is we have done this state by state. And the blue are doctors in these villages with an MBBS degree. Red is Ayush, mostly Ayush, and green is no degree. right? What is very interesting for me is it's not a North India and low income problem, right? It's everywhere. So even if you look at Tamil Nadu, where we have many fewer providers, half of them have no formal degrees. If you look at the only place that's eliminated them to some extent is Kerala, right? Everywhere else, even if you look at Andhra Pradesh, they are 80% of your providers, right? So these guys are not going away. That argument that's worked in Thailand and Sri Lanka, which is we strengthen the public sector and the informal providers go away, is just not there. What we are finding instead is that the informal providers improve, but they don't go away, right? So what are the numbers? So 77% of providers have no degrees, 18% have some other degree, and 4% have an MBBS degree. So the average village in India has about 0.18 providers with an MBBS degree. The other way to think about it is about every 15 to 20 villages will have an MBBS provider somewhere within 10 to 15 kilometers, right? Okay. Same, what I find very interesting is urban providers. So again, you can think about it as saying this is a rural India problem, right? But it's not. So even if you look at Patna and Mumbai, in Patna, there are equal number of informal, and I'm using Ayush and Ayurved right now is informal because in all our data we find no difference between their practice and the practice of people who have no formal training. So this idea that Ayush is somewhere in between is just not there in the data, right? So these guys, they're exactly as many informal providers as there are MBBS doctors in Patna. It's roughly the same, right? If you look at Mumbai, the informal providers get replaced by Ayush, but again, there are about as many Ayush providers. This is just 4 wards data, so it's, for those who know Mumbai well, it's Andheri West East, it's Malad in the north, it's Kurla, and then it's Dadar. So it's, there are equal number of these Ayush guys as your MBBS. So even when we are moving to an urban high-income setting, and Mumbai is about as high income as India gets, or Delhi, you still have a very, very large number of, you can call them less than fully qualified, you can call them informal, whichever way you want to think about it, right? So just to give you some idea of spatially what does this look like, so these are villages in 2 districts in Madhya Pradesh, and these are both pretty deep tribal districts, and these are sample villages. So what you typically find is this is the state highway, or a local highway, and this is the local highway. You'll typically find here's a sample village. There's maybe 1 provider inside it, but then there's a cluster on the highway, right? I mean, that's what you typically find in all these areas, right? What does urban look like? This is Patna, for example. So those of who know Patna know that it looks like an elephant, and it's not that the informal are sitting somewhere and the formal are sitting somewhere else, right? These are all places that are very close together. Again, that just partly reflects our own population structures. We do have very little segregation in India compared to other countries, right? So if you take Defense Colony, just opposite Defense Colony is Kotla Mubarakpur, right? I mean, you take the WHO building, just behind it is a huge slum, right? So you'll always get people living together, and you always get these 2 types of providers in the same area. So they're not separated by distance, right? So the way I like to think about this is all this choice is going to imply that whatever policies we do will be swayed by our mental model of how we think about this choice, right? And the 2 key questions that I think guide the way we frame our policies are 2, which is, one is, do providers, when faced with a patient, provide appropriate care for both men and women, right? And can patients, mothers, families assess quality and make appropriate choices, right? And if you think about the way global health is structured, it's that most policy is predicated on the belief that doctors provide appropriate care and patients make poor choices, right? So if you think about it, why do we have a conditional cash transfer for getting women into institutional care? It's because they can't make the right choice on themselves, right? Because we need to give them incentives, because otherwise they really don't know what they're doing, right? And I've interviewed maybe 300 doctors throughout India, And always the story is the same. What's going wrong? यहाँ पर तो गरीब लोग लेते हैं, इनको तो मालूम ही नहीं है, वो देखो रात को दारू पीते हैं, वो तो नहाते नहीं है. The number of complaints about the behavior of patients is primarily where the blame in the system is put by the providers, right? So I call this mental model the good doctor, naive patient model of the world. It's not specific to India. This is a general global health formulation of the problem, right? Which is any behavior on the part of the patient is bad. वो दवाई नहीं खाते, there's a problem with adherence, there's this, there's that. It's always, since I was young, सर्दी क्यों हुई है? Because तुम स्वेटर नहीं पहन के गए, right? I mean, no, it's not the patient's issue. Is a good point to start, right? So what I try to put together is how do we think about these mental models, and the way I think about policy in India is it's dominated by this old mental model, and this old mental model has kind of 7 parts, which is if you have medical education, it implies competence, right? So MBBS are all good, non-MBBS are all bad, right? What I'm going to show you is that yes, medical education increases competence, but with huge variability, right? You can get an MBBS degree that does virtually nothing for you. You can get an MBBS degree that brings you up quite a lot, right? The second part we believe in this old mental model is effort is consistently high. It's this idea that doctors take the Hippocratic Oath. They're there to help patients. That's their mission in life, and they fulfill it, right? What we find instead is that effort is very low and exceedingly variable, right? The third part is this whole thing that's risen on antibiotics and unnecessary drugs, and we have happily parsed that out and blamed the informal sector, right? Why do we have this problem of antibiotics and unnecessary drugs? It's because we have lots of quacks going around, right? I'll show you data that is actually much higher in the MBBS in the public sector, right? What is happening with the work environment? The public sector has no equipment or medicine to look at, and in fact, it looks okay, and it's actually improved a lot over the last 10 years, right? The next one on the mental model is patient load, which is the general idea is that the public sector patient loads are too high to do any good, right? I'll show you data that is too low. Most doctors don't have work to do, right? What about patients? They're naive, they cannot make good decisions. I'll show you evidence they're actually fairly sophisticated and they make fairly decent decisions, right? So if you think about this, mental model is very consistent in itself, right? Which is you say, the problem of healthcare is patients can't make good decisions, which is why they're not coming to as much as they should to the public sector. And doctors, on the other hand, are trying their best, but they're constrained by the fact that they have so many patients and they don't have equipment and medicines. And then these guys are consistently fooled by these quacks and Ayush, and they come too late to us. It's a very consistent model, but it's basically wrong, right? And I think one of the big things that we do need to think about is how do we get people to start switching their mental model on the basis of the data. Right? So a lot of the data I'm going to tell you is not that hard to collect. It's time consuming, it is backbreaking, but it's easy. Some pieces of it are actually fairly easy to collect, right? So for instance, 3 years back there was a newspaper report that, in a public health facility in UP, the janitor was doing deliveries, right? I don't know why that's a newspaper report. On average, if you go to a PHC in a rural area, 60% of the patients are being treated by somebody who's not the doctor. Right? It's the doctor is absent, it's a compounder, it's a janitor, it's a sweeper, it's somebody else. It's literally, 2 days work, right? But we are not putting that together, and I want to understand why is it that we are not putting these simple pieces of data on the table, right?
Where's formal private sector?
So the formal private sector is not totally in the model. It enters kind of here, right? And it so the whole formulation of the formal private sector is primarily that they're doing a lot of unnecessary drugs and testing, that they're better, but they're inflating costs because they're doing a lot of unnecessary drugs and testing. But you're right. I mean, I should have a more careful idea of how to.
Dual practice, right? So
so I'll show you something.
That's
Yeah.
also.
Yeah. Okay. So what I want to do in this presentation is I'll quickly take you through, an idea, just an example, and these are going to be snapshots, so I'm not going to dive deeply into anything because otherwise we won't have time to discuss. But, so you should trust but happily verify afterwards, and I can give you papers or we can talk through things. So these policies based on this good doctor, naive patient model have essentially failed, right? And I'll give you one example from childbirth and the JSY. But fortunately, aspects of this mental model are actually amenable to empirical analysis. You can directly test whether these ideas, these pieces of these models are there in the data or not, right? So I'll discuss some results from this empirical analysis, and I think we now have to think about where this leads us. And I think we are constantly stuck in this problem now for the last 15 years that I've been working on this, that we are unwilling to switch from the old mental model, and we are constantly trying to fit new policies to this old model, and it's not going to work, right? So example of JSY. So here's child mortality in India. It declines quite sharply between 1980 to 2005, but we are still not on target to meet the Millennium Development Goals, so we decide we should accelerate this. It's going to be driven by this idea, which is, again, we are always mimetic and mimicking what's happening in the global health scenario. So the idea has to be that it's because poor people don't know better, they're giving birth at home with these untrained dyes, we must bring them into the public hospital. The only way to do that is to give them cash. So we have two schemes. We have the Chiranjeevi starts in 2006 in Gujarat. So it's a PPP that pays below poverty line women to cover the cost of delivery in private hospital. It's heralded as a large success. 90% reduction in maternal deaths, 60% reduction in neonatal deaths. Then it gets the ultimate seal of approval, which is the Asia Innovations Award in 2006. And it leads to a scale-up in terms of the Janani Suraksha Yojana, which became the world's largest conditional cash transfer to women, for women to deliver at public clinics. There's some eligibility criteria that differ by state, BPL status, SC/ST status, number of children. And there's an article in Lancet, which implies that it's true, by Lim and others, that argues it was a big success, right? So what's really the case? So if you re-examine the Chiranjeevi, Manoj Mohanan and others have a great paper in the bulletin on the WHO, which I suggest you have a look at. And they say that their findings indicate that the Chiranjeevi Yojana program was not associated with changes in the probability of institutional delivery, maternal morbidity, or delivery-related household expenditure. Forget mortality, it didn't even bring people into clinics, right? So we have these dual problems. I mean, we really have this issue that serious analysis is not done on programs, but program success is claimed on the basis of completely spurious information, right? If you look at JSY, there are a number of papers that now find that JSY increased institutional deliveries, and Amrish was one of the people who worked on that. But Lim et al. Just got it wrong. I mean, they compared women who received the cash incentive and those who did not, which is a bad way to do program evaluation because it's a selected sample. You have to compare people who are eligible and people who are not eligible, right? And when you actually do that, and Thomas Powell Jackson and Ann Mills have a paper on that in the Journal of Health Economics, there's just no impact on mortality, right? A bigger problem is that the data itself is highly suspect, right? And what do I mean by that? So Shareen Joshi at Georgetown and I are working on this. Here's what the data look like, right? So when you complete that series, this is where JSY comes in. You have a sharp decline till JSY comes in 2008. After that, there's no change in infant mortality. Right? So we are trying to wonder where Lim et al. Got their result. And it turns out, and this basic pattern of a decline in 2008 and then completely stable is true for all states in India. Right? So it turns out when you look at the data in some detail, there's a jump down in 2004 to 8, and JSY comes in exactly over here. Right? So what Lim and all pick up is this average versus this average, and clearly this average is lower, right? But as statisticians, we hate it when there's a jump downwards in a year when nothing major was changing in the world, right? So we started to go back to the data and said, why did this jump happen? And one thing was there was a single overlapping year where 2 different rounds, the RCH2, the DLSY, this DLHS2 and the DLHS3 overlapped. So for 2004, we had data from DLHS2 and from DLHS3, right? And those 2 numbers don't match up at all, right? So we had to go back and look through the questionnaires, and it took us almost 7-8 months because we had to rule out 30 different things. So for example, the DLHS2 got stuck in court. So if you look at how it was not done in a continuous manner. It was done in different months. Usse ho sakta hai, isse ho sakta hai. What we finally discovered was quite simple, which is that stillbirths and induced abortions were counted as separate in DLHS3 and they were counted as part of mortality in DLHS2. Right? And the moment you account for that, you see that the 2 surveys line up very nicely and there's just no effect, right? Basically, the moment JSY came in, our decline in infant mortality halted, right? I don't know what's happened after that, and now we have the new DLHS that's just become available, so we'll see what's happening. The interesting point here is that this thing that that institutional deliveries is what matters, we're just not finding it anywhere. So Okeke and all, and very nice papers from Rwanda on a similar conditional cash transfer, and Okeke and Godlunton have a fantastic paper from Malawi which banned informal providers from helping out with birth, that hugely increased public institutional deliveries with no effect on infant mortality at all, right? So there's now 3 countries where we're finding just no impact of this idea that people were not coming into facilities because they didn't know better. Right? So what does that? So where is this coming from? Where do we think this is coming from? I think it's coming from this old model, and I want to show you each of these pieces that we have pieced together over the last kind of 14-15 years, and then just open it up for discussion. Right? So first idea, that medical education produces highly competent people. This is MBBS degrees across states and how they answer on tests with very simple diagnosis of TB, dysentery and preeclampsia. A person with an MBBS degree in Uttarakhand, Uttar Pradesh, Jharkhand, Bihar, Punjab, Uttaranchal, Madhya Pradesh is just a different category with a person from an MBBS degree in Kerala, Gujarat or Tamil Nadu. Right? An MBBS degree in these places, you have a 51% chance of correctly diagnosing TB. When given a written test or close to a written test, 12% chance of correctly treating dysentery, 16% chance of correctly treating preeclampsia. The same person, an MBBS degree from Tamil Nadu will get you 93%, 91%, 94%, right? Yeah.
What exactly do you mean? Is it MBBS doctor in Tamil Nadu or a person with MBBS degree from a Tamil Nadu institution?
They're virtually the same because there's no state, so we find 3% of doctors are practicing in states where they didn't get their degrees. So there's very little mobility. And you can see why. I mean, there's no way to have mobility in a system where the MBBS degree means something completely different in every state, right? Even within, so what does this actually, I'll show you a startling number. In each of these states with the tick mark, the informal providers are actually better than in other states, right? So if you look at all these tick marked states, they're actually better than the MBBS providers from Bihar.
When
right?
you say better, meaning
More knowledgeable in this test.
How do you find that?
Through a test. It's a thing called vignettes where we present patients to them and ask them what they would do. Right?
So through a process.
Through a process, through the same test administered to 12,000 providers across India. Right. So this would mimic roughly what the Niti Aayog's proposal on a centralized test would give you. Right. In fact, if we do the centralized test and we take Tamil Nadu benchmarks for an MBBS, nobody in Bihar passes it, right? I mean, that's going to be an issue, right? Okay, so even in a single city, so this is Delhi, if you look at public sector MBBS doctors, they are all over the place, right? Essentially, whether you got your degree from Lady Harding or from somewhere else or from some other private university, you can go anywhere with an MBBS degree. And you guys, everybody in Delhi living knows that. I can find an MBBS doctor who knows nothing, and I can find an MBBS doctor who's really, really good, right? So that's our second stylized fact. Third stylized fact is effort is very low. So in India, average patient interactions last 3 minutes. The doctor asks 3 questions, performs 1 exam. So this is generally, in the public sector, it's 1 question and 0 exams. It's normally tumhe kya hua hai, right? Kya bimari hai, right? And you get similar results in some other countries, but not others, right? So, this is doctors, this is 1/3 of patients. So I've divided this. Green is 1/3 of patient interactions, blue is 1/3, and this is 1/3. So the guys who are in the bottom 30% of patients, they get 2 minutes with the doctor, 1 question, and no exams, right? I mean, that's what care is like in Delhi. Right? So what do these two things together imply? There are very significant deficits in our quality of care, right? So I'll show you some data, but in rural Madhya Pradesh, we send in patients who are mimicking signs of unstable angina, asthma, and child diarrhea. The child is actually at home because we can't send in a child. And they're very well trained, and we've gone through enormous trouble to validate the method, get all of that done. So in rural Madhya Pradesh, about 30.7% of patients receive correct treatment. And correct generously, which is at least you did the right thing, you might have done a lot more things. And we use that because if we try to say correct treatment without giving additional things, it's 2.6%, right? And 36% incorrectly give antibiotics for asthma and angina, right? So what that implies is this what we call a significant no-do gap in the quality of care, and that's higher among MBBS providers and in the public sector, right? So one of the things I'm working on with Akash Mopal, who's now at the World Bank, he's a Michigan student, is that the majority of wasted money in the system is due to under-treatment. It's not over-treatment in primary care. It is under-treatment. And I'll just show you what those numbers look like, right? So I'll just show you exactly what those mean. So just very quickly, quality can be very poor. This is a heart attack patient. He goes to the doctor and he says, doctor says, तुम्हें क्या हुआ है? सुबह मुझे बहुत छाती में दर्द हो रही थी. ऐसा लग रहा था कि मेरे छाती पे कोई बैठा हुआ है. Somebody sitting on my chest. I had enormous chest pain. और कुछ हो रहा है? Anything else going on? और कहीं दर्द है? हाँ, मेरे हाथ में ऐसे दर्द हो रहा था. Right? There was a pain shooting down my arm. And this is as obvious as it gets. So he gets about 4 minutes, 3 questions, 1.4 exam, 2.34 medicines. If you start looking at how many order an ECG, it's 24%. How many ask about smoking, 7%. How many ask about pain radiation, 16%. Anything, they do ask ki exactly chhati pe dard kahan par ho raha hai. They do ask that. They tend to do, some things like they do check with the stethoscope where, what's happening. 36% check the pulse. So it all looks not very nice. And correct diagnoses are given about 9% of the time. So the guy actually gets worried. There's some of these guys were really good. So we've had cases where the guys, tum kahin mat jana, don't go anywhere. मैं अभी motorcycle रह रहा हूँ, scooter रह रहा हूँ, उस पे बैठो मैं तुम्हें hospital ले जा रहा हूँ, right? And then this guy, the roads are really bad, and a guy got off and started running across the cornfields with this guy, shouting at him, अगर तू मर जाए तेरी जिम्मेदारी है, I'm not responsible. So these are fantastic patients that we have, and we also get very, very good doctors, right? So what do they do when they get the wrong diagnosis? They think it's blood pressure, they think it's gas, they think it's muscle problem, and then our most common one is change of season, which is, one of our fallback options for anything else. But the other distressing part is, about 56% don't even get a diagnosis, right? So the doctor doesn't tell you what's wrong with you. And we tried to address this econometrically by randomizing some of these patients just as they were leaving would turn around and ask the doctor, Doctor Saab, mujhe hua kya hai, right? And that increased diagnosis rates, giving the diagnosis by about 6-7%. But the others got shouted at, right? I mean, saying ki, तुझे क्यों पता करना पड़ेगा, तू डॉक्टर है या मैं डॉक्टर हूँ, right? I mean, are you the doctor, right? So, and this is child care. So this is work that Priya Agarwal and Atul Gwande led. This is one sub-district hospital in Karnataka. And if you look at what's going on, so from pushing till delivery, appropriate hand hygiene, 10%, cord cut with a sterile blade, 12%, on soon after birth, postpartum counseling, 0.5%, newborn infection management, 0.3%, Maternal infection management, 37%, right? I mean, it's basically abysmal. And the reason why women were not giving births in facilities is because it's terrible. Right? So all we have done is we've managed to say, take some money and please give birth in a terrible facility and not at home. Right? And it's not surprising. It's not brought our infant mortality down. So what does this also mean in terms of the no-do gap? So here's tuberculosis in Delhi. When we ask doctors, so this is a patient who has 3 weeks cough, मुझे 3 हफ्ते से खांसी हो रही है. I went to the local chemist, I got some medicines, but I'm not feeling better. When we ask them what would you do with such a patient, 60% say I would suspect TB. 68% said I would get a CXR, a chest X-ray. I would ask about sputum. I would ask about blood in the sputum. I would ask about a bunch of other things. But when we actually send in our patients, the gaps are just enormous where it matters. So chest X-ray, 68% said they would do it. In practice, 10% of them say they do it, right? TB suspicion, 60% say they would do it. When we send in the same guy, 8% actually do it, right? So we see this across the board on everything, and now these results have been replicated in Canada, US, Rwanda, Tanzania, and Vietnam. So this is a general phenomenon with healthcare, which is
magnitude of the gap.
The gaps differ. So Kenya, for example, is much lower than India, but they're very large, right? So here's another way of thinking about it. So this is from Madhya Pradesh. As you can see, the private and public MBBS providers know how to treat these cases correctly about 90% of the time. So they're pretty knowledgeable in this particular sample for these cases, but they actually do it in practice 38-39% of the times, right? Our informal providers know how to treat it correctly about 60% of the time. They'd get it right about 24%, right? The part that surprised me a lot was this. I wasn't surprised that unnecessary antibiotic use increased over what they thought they knew, but antibiotic use is much higher among the private MBBS providers and the public MBBS providers than it is among the non-MBBS providers. It's almost double, right? And the interesting part is the MBBS providers seem to know that you should give antibiotics for a heart attack, right? So there's something going really wrong with our training when we are training people to know that you should wrongly give antibiotics, right? I mean, so this is, something I don't understand fully yet, but we have replicated. I'm not giving you results from one place only. We have replicated this in Bombay, we have replicated this in Patna, West Bengal, and Delhi, right? So these are results we are finding across India in a number of studies, okay? So what did I mean by where is our costs coming from? Here's what we did. When a doctor gave a correct treatment, we said all your costs are appropriate, right? When they undertreated you, which is you came in with a heart attack, but they told you you had gas, we are saying all your costs, medicine and consultation, are not required. You got nothing out of that consultation, right? And when we overtreat, which is I did the right thing for your asthma, I gave you an inhaler, but then I also give you antibiotics, we keep the consultation cost as required, but then split the medicines by the ones you need and the ones you didn't need. The ones you didn't need, we say is wasteful costs, right? So what you end up getting is about 72% of our costs in primary care are medically avoidable, and 92% of this is due to undertreatment, because the moment you're undertreated, your consultation cost is completely wasted, right? Where is this coming from? It's happening everywhere. The highest avoidable cost is for non-MBBS providers because they are undertreating. They don't, their knowledge is not that high. But if you look at terms of numbers and public MBBS providers, for example, our cost per consultation in a public sector clinic is about 350 rupees, and the avoidable cost is about 221 rupees per patient, right? If you look at private MBBS, the cost per patient is about 82 rupees and the avoidable is about 47, right? So we just have phenomenal waste in this system. We can get exactly the same, if people were doing the right thing, we'd get exactly the same thing at 20% of the cost, right? So it's not a budget issue. Okay, so I'll run through these quickly now because that was really the main part of explaining the environment. So what do we know about equipment and medicine? Sorry?
What's the cost in the public?
It's the wage cost of the public employee divided by the number of patients they're seeing. Okay. So equipment and medicines, it's looking pretty good in the public sector, at least related to the private. And now we have this for all. So I'll show you two different things. We have this. Let me show you this first. Let me show you this first, which is all states and their PHCs. They're all looking okay, right? I mean, the stethoscopes are there, the BP instruments are there, torches are there, scales are there, wash basins there, all of this kind of stuff is there. And we've seen pretty large increases from 2003 to 2010 in every single item, right? And in a broad infrastructure. So that part of it, NRHM managed to do, right? The second part of it that I wanted to show you and that was very surprised about is we are not very far off between sanctioned doctors and posted doctors. In India, it's 2.9 sanctioned to 2.3 posted. Not surprisingly, in a place like Uttar Pradesh, that gap is a little higher, especially with nurses. And we see the same thing in PHCs and CHCs. In Uttar Pradesh, again, the gap is a little higher. Uttaranchal, the gap is higher, but it's not huge, right? The part that's really surprising is this, which is, so we've got about 2.3 to 4 providers per PHC. Look at the patient numbers, right? So Madhya Pradesh, 30 patients a day means each doctor is seeing about 14 patients a day. How much time are they spending? 3 minutes. 14 times 3 is 42 minutes. That's their workload for the day. Okay. So we were very surprised with this because this is taken from PHC registers, and there's some places, Tamil Nadu, they're seeing a lot of patients, right? But generally in rural PHCs, Chhattisgarh, 18 patients a day with 2 doctors sitting there, right? So we actually spent in 100 PHCs, we just sat there the entire day and said, "Kya ho kya raha hai," right? And the green is the part where these guys are not working, and the red is where they're working. Right, so these are our busiest public sector CHCs. These are our less busy public sector CHCs. They are basically empty. Right? Okay. Number 6, OPD. But let me just rush through this a little bit. So, again, on public and private care, these are, again, what Jorge was saying, these are dual practice guys. We find that public sector doctors in their public clinics tend to be even worse than the informal providers. In their private, that's not true. Public clinics tend to be the worst, but in their private clinics, they are the best doctors by far in the systems, right? So there are these huge differences that are coming from where you are, right? So last thing on patient decision making, and then I'll probably stop, which is, so technically, it's really difficult to demonstrate patient sophistication, right? The way we do this in economics is we try and link what people pay and the quality they receive. And the idea is the following, which is, if people don't know the quality of what they receive, we should not find any link, right? So imagine I'm paying 100 rupees for a good doctor and 30 rupees for a bad doctor, right? It must be the case that I know who the good doctor is. Because if I have no idea, the bad doctor will also charge 100, right? So we do this in 2 ways, between how much people are willing to travel and how much money they're willing to pay. And we find 2 things. We find that better treatment, getting it right, is strongly incentivized in the private market. But there are no disincentives for doing a lot of additional things. Right? So there's no cost control mechanism to the private market. So what do I mean? Suppose there's a good MBBS doctor and a bad MBBS doctor, right? The good MBBS doctor will charge you 500 rupees in say, wherever they are. The bad guy is 50 rupees, right? The problem is, it's not, take 2 good MBBS doctors now, one who will give you only the right things, the other who will layer on a bunch of tests and medicines. In a good, well-functioning private market, the second guy should be out. They shouldn't be able to do it because as a patient, I prefer the same care for a lower cost. But that doesn't happen in the market, right? So let me just show you two things on this. So here's distance traveled, which is from 100,000 people in Madhya Pradesh whose movements we tracked. And it's pretty clear, whether you're low socioeconomic or high socioeconomic status, the further you go, the higher the knowledge of the doctor you're visiting. Right? That's really sharp, because on this scale is measurements that we have made from vignettes. These are objective measurements of quality. This is how much they're willing to travel. So every kilometer extra that these guys are willing to go, they're pushing up quality by about 0.4 standard deviations, right? The other part of this, which is the difference between these two, is basically saying for the same competence, poorer people are traveling more, right? So what's happening is that the rich guys are going to better people who are in their neighborhood. The poor guys are traveling further to bigger markets where higher competition is lowering their prices, right? But they're really fighting to try and get this right? We find exactly the same thing with prices. So doctors who are doing very little are able to get about 10 to 15 rupees per consult. Doctors who are doing a lot of the right stuff are able to up it to about 50 rupees. This is rural Madhya Pradesh. And here's data from Mumbai and Patna. So you'll see that across the entire span in Mumbai and Patna, the Ayush and informals are sitting here, and these are the MBBS guys, and it's very clear that the more likely they are to get your condition right, the higher the consultation fees, right? And these are strong markers of patient sophistication, right?
Did you figure out how the information actually disseminated?
It's really hard. I mean, we don't have a good model.
Word about?
We don't have a good model for that, but so far at least just demonstrating this fact, right? So if you think about कि patients को कुछ मालूम नहीं है, their health is this is a sacred cow in both economics and in health, that patients cannot tell the quality of care they receive because health is very complicated, right? So these are kind of the first times we are showing results that that's not the case, right? Okay, so
What is the quality measure here?
it's standardized patients. So it's patients we send in.
Patient.
Yeah. Right. Okay. So I want to
Just
just
one second.
yeah.
Line ahead.
Is there a direct correlation between the quality of the doctor you're seeing and the charges that he's? So is a good quality doctor, as you define it, charging more, and a bad quality doctor charging less? Have you seen that?
Yeah, that's exactly what this is.
But so that's two different things. Like a patient might pay more for a low quality doctor. So a low quality doctor might charge more. So I'm just kind of trying to figure out if the correlation is very strong. The high quality doctor is always paying more, is always charging more, and low quality doctor is always charging less.
So here the correlation says if you have a 10% chance of getting it right, you charge about 100 rupees. If you have a 75% chance of getting it right, you will charge about 750.
She's asking for the goodness of it.
Yeah, I don't know how to theorize about the goodness of fit. We don't have a good, it's not that the R square on this is 1, right? There's tons of other things going on. Okay, so I just want to end with one thing, that these incorrect mental models are leading to poor policies. And I want to take one example which is in the discussion space right now, which is these deep interconnections between medical education, effort, and financial compensation that I think are insufficiently recognized. I'll give you one example, right? So here's our starting point for this example. So we all know this. Lots of people are paying bribes to go to medical colleges. As an economist, this is a very funny and weird thing for us to understand, because as Times of India also says, and Times of India always says the truth, is many of these colleges are running with little or no facilities, no patients, and fake facilities, right? Then CNBC is definitely not fake news. It's on medical colleges hiring patients to lie in beds to show enough patients to provide students with clinical experience to government inspectors in Muzaffarnagar. All of this we know. I like the quote, which is the school's principal said, "I'm not very keen to reply." Right? Fine. We also know about the Vyapam scam. So a lot of people died. And for us, this is a puzzle, because why are people willing to pay large sums of money to attend what in the US we call degree mills? Why? You're not going to get anything out of it, right? So it must be that the returns to this degree are worth the money either in the public or private sector, right? So here's what returns to performance look in the private and public sector, right? So first of all, public sector pay is much higher than private revenue for the vast majority of doctors. So leave aside the Apollos and the this thing and whatnot. 95% of your doctors are sitting in a small town somewhere, or in Bhagwanpur Khera here, or Noida 8 block there. That's where your MBBS guys are going, right? So I've been going to a lot of the private medical colleges and just talking to these guys at the cafes and saying, "Tum yahan kar kya rahe ho, right? What are you doing here?" And they're very clear to say कि देखें यहाँ की डिग्री से मुझे दो ही उपाय हैं, राइट? आई ओनली हैव टू ऑप्शंस. या तो मैं शहर में जाके कहीं बस्ती में क्लिनिक लगाऊंगा, आई पुट माय क्लिनिक इन अ बस्ती, या मैं मुझे गांव में जाके छोटा सा शहर में रहना पड़ेगा, राइट? बट आई एम गोइंग टू अप्लाई फॉर अ पब्लिक सेक्टर जॉब एवरी ईयर. अब पब्लिक सेक्टर में डिग्री तो डिग्री ही है, right? So it doesn't matter where I get my MBBS degree from, I'm going to get exactly the same salary, right? So you have created a system where so the private sector very clearly recognizes where you got your degree from, how good you are. The public sector does not. And it's paying you much higher, which is why you're going to get a race to the bottom. So you're going to get basically in a classic model, you're going to get two things. You're going to get some colleges providing minimal training. These are essentially educating people to go into the public sector. Or you're going to get some colleges providing excellent training and the graduates are going to go to a high-paying private sector or to emigrate, right? So what I don't understand is unless you address, so either you have to start addressing what's happening in the public sector on pay, right? You can't do it by just looking at medical education. You have to say, why is it that medical education is poor? It's because my medical education doesn't count in the public sector at all, right? And that's where I'm aiming for. So let me stop there and give you two quick things. So three things. One is we do not yet understand how and whether financial subsidies can improve this quality of care. That's been most of the discussion in India. And I think that in general, there's a very insufficient understanding of market structure and how financial subsidies will alter this, and very low human capital in our states to manage financial subsidy schemes. And there's nobody around, right? When we started on RSBY, we thought, things will pick up. But even now, if you go to a state which is implementing the scheme, there are two people who are managing a scheme for, 20 million people, 30 million people. And those two are part-time, right? If I think about Thailand, there are 1,000 people who are managing their insurance scheme. So what you need for RSBY to work is a staff of 1,000 in every state. Short of that, it's not going to work. So, we have now two examples from training informal providers. This is a paper in Science that shows that, training informal providers for 72 sessions, right? So that is 72 multiplied by 4, 300 hours over 9 months, had a large impact on their quality of care and actually brought it up to public sector things. We also have an example now. I've been working with the Gates Foundation in Mumbai and Patna, working with different private sector providers and with large market penetration at scale, and we find massive improvements in their ability to diagnose TB, particularly in the use of what's called microbiological testing in tuberculosis. But again, financial incentives are not the story, right? So in these programs, they can give vouchers which they get an incentive for, right? And when we send in our patients, we noticed there were 800 vouchers they could have gotten, but only 160 were actually given vouchers. So 80% of these cases, the doctors don't even bother for the vouchers for which they get 100 rupee incentive. They don't even care, right? मुझे इस scheme में घुसना ही नहीं है, right? I just don't want to get into this complication of vouchers and financial subsidies and all of this. They don't care about it, right? So this idea that we can solve everything with financial structure and subsidies just seems to be incorrect. So let me just conclude. I think, this part is starting to gel together. That basic mental model, which I think is true for most of global health, is just off on such a wrong way that, we have to pull it back. And we're now starting to see that instead of thinking about what the global health community calls fragmented private sector and things like that, you say that what are policies that fragmentation is very sophisticated.
You say fragmentation of the market? Or
So the fragmentation, the way people think about it is to say there isn't a single aggregating institution. De jure aggregating institution. There's nobody I can go and talk to who will then disseminate everything through all private sector clinics in Delhi, right? And that's why nobody wants to touch it, because kiske saath baat karoge? They're all independent things, right? But that market is very sophisticated, right? And policies that can start to exploit that fragmentation seem to be more successful. But the problem is this, the reason we like financial subsidies and things, it says hands off. मैंने iPad ऐप बना दिया, पेटीएम बना दिया, ये भेज दो, मुझे पैसे मिल जाएंगे, right? That's it. The programs I'm showing you successes from are very human capital intensive, right? In the Mumbai program that we're working on TB, each of the staff takes about 180 to 200 phone calls a day. कि यहाँ पर ये हो गया है, वहाँ पर ये हो गया, इस पेशेंट का ये हुआ है, इस पेशेंट का वो हुआ है. These are not easy for the government to take over as they are under current human capacity constraints, right? So, it's not financial incentives. What it is harder to do, right? So I want to stop there and, just make sure that we have sufficient time for discussion. So that's kind of what we have learned over the last 15 years, and at least it's robust. I mean, we're finding this everywhere. It's not one place, incorrectly done study. It seems to be pretty global. It's not India. And I'd love reactions and start to think a little bit about if you're willing to accept these as stylized facts by now, and maybe we should relitigate some of them and see what needs to be done. How can we start moving forward with some story about even small or state level things that could be done and piloted?
Thank you, Jishnu.